Dr. Robert Roberts is the president and CEO of the University of Ottawa Heart Institute and director of the Ruddy Canadian Cardiovascular Genetics Centre. Dr. Roberts has had a distinguished and prolific career as a cardiologist, educator, and scientist, having published over 800 scientific articles. He was awarded the most highly cited researcher in 2002. He developed the MCBK test, which has been used to diagnose heart attacks for the past 3 decades. Dr. Roberts is regarded as one of the founders of molecular cardiology, which led him to the discovery of several genes for heart disease. And his topic today, personalized medicine and coronary artery disease. We are delighted to welcome Dr. Robert Roberts to the stage. Thank you for being here today.
Well, good afternoon, I guess, everyone. My topic is a little on personalized medicine, but it's mainly related to coronary artery disease and where that role is overall going. And so I assume part of my function today is to give you a brief understanding of personalized medicine as we see it now and in the future. And certainly, those conflict of interest, none of them relate directly to what I'm going to say, but there they are. Certainly, the definition of personalized medicine, as I would see it, and I think as most people would see it in the future, is, of course, going to be based on your genetic variants. That, of course, means that somewhere in the future, in order to truly fulfill this dream, you have to have available those genetics that relate to that particular drug or disease that you're interested in. Hippocrates once said it's far more important to know perhaps the person in whom the disease occurs than it is just to know the disease. Now, certainly at that time he wasn't thinking of personalized medicine, but he was realizing that the same disease or the same drug in different individuals had often a different effect and a different side effect. And from that perspective, he realized that the body reacted differently even to known diseases at that time or known treatments that they would have had. And this clearly, of course, is what has brought forth the concept that as we go forward to have personalized medicine. There are lots of reasons for having personalized medicine, but first and foremost, we now know that Hippocrates is absolutely correct, and in fact, that all diseases have some genetic predisposition. If you go and fracture your hip, the response in healing is going to be different. If you get a blood thinner such as warfarin, we know that your response to that drug is different. And so we believe and strongly now have data to show that most of that variability is related to your genetic variants. The FDA, for example, estimates in the United States that adverse drug reactions is the fourth most common cause of death in the United States today. That means, and you've all seen various articles written, such as the New York Times, saying that over 50% of drugs used today are used inappropriately and ineffectively. I'm not saying that that is an absolute correct statement, but I think all of us are aware of adverse effects where it's difficult to adjust the dose in a particular individual. And I think all of us know in our daily use, certainly, that there has been a lot of interest in terms of that. I would say in cardiology, we are a little behind in terms of genetic testing. In cancer, certainly it's already well versed. If you go into any major cancer institution today, you will be tested from anywhere from 40 to 100 different mutations, not only for that particular cancer, but also for that particular drug. For example, that the drug that's most popular for cancer of the breast, it only works in about 20% of women. So you test them for the leptin receptor. If they don't have the gene for that receptor, then you wouldn't give the therapy. And so cancer is moving along. Of course, they have an advantage because all of cancer is due to a genetic defect. You can't get cancer unless you have a defect in your DNA. It may be induced by carcinogen, or it may be something that you were born with. So that certainly today a big push is on to personalize medicine in the case of cancer. The two examples that we have in cardiology is clearly Clopidigrel and Warfarin. Clopidigrel came into being because it's an anti-platelet agent, and we recognized very early in the game that 20 to 30% of people getting it, whether it was following angioplasty or following bypass surgery, did not have the response, and when they checked the platelets, they in fact were still sticking as though the drug was not working. And from that evolved, we now know that there are several genes responsible for this, and certainly the CYP19 is the predominant one, and you can test for it today. The same with Warfarin. FDA, as you know, has put out a test that you can do before you give Warfarin. That trial is ongoing at the moment, and it's the first prospective trial that's ongoing, and the results are not yet available. Both of them, again, indicating the fact that there is an important component to choosing the drug. So if you look, and certainly there have been several articles published, none of which I have co-authored, to point out that this is the last century for heart disease, that heart disease can indeed be prevented. Now, the evidence for that is we know that clinical trials have consistently for past 40 years shown that you can decrease 30 to 40% if you treat those people with drugs that we already know today. And I think if that is true, we already know, of course, and this is well documented for 50 years, epidemiologists, family studies, and twin studies, that about 50% of your susceptibility for heart disease is in fact located in your genes. And so if you have premature heart disease, probably a much higher percentage is due to that. We have known for a long time that people can have heart disease even though they have a normal cholesterol, normal LDL, normal HDL, and they're not hypertensive, etc. And so it is well respected, well documented, that in fact there is a genetic component. Now, certainly we also recognize that our known conventional risk factors, such as cholesterol and hypertension, they too have a genetic. It isn't just some mysterious thing with myocardial infarction. All of those known conventional risk factors have a genetic component. For example, we now know today that LDL is about 80% determined by your genes. All of you are aware, cholesterol, over 80% of it is endogenously produced, not what you take in or eat. And it's very much regulated by your genes. HDL is said to be more than 80%. And in fact, we've finished studies showing that we've identified 32 genes that regulate cholesterol, the LDL, and 31 genes that regulate HDL, and they've already been identified. So from the point of view of looking at preventing heart disease, I think all of us would agree comprehensive prevention will indeed require prevention and in some way inhibiting the effect of these genetic factors. A major barrier until recently was, of course, having those genes. And in fact, it wasn't until 2005 the technology arrived to identify genes for coronary artery disease and myocardial infarction. That was the so-called Genome-Wide Association studies, where one could run across the genome in a non-biased way with a variety, hundreds of thousands of markers called SNPs, and identify the basic concept being you took thousands of cases of people with heart disease and thousands of controls, and you analyzed with those markers, and if the marker was more common in those with the disease than the control, then you said that marker's in a region that has a risk for the disease. It had to be a very stringent story because you're using so many markers in this case, so you had to have a p-value of 10 to the minus 8, which is very stringent. But that's the system, and these were the chips that gave us the opportunity to do first 500,000 markers, subsequently 1 million markers, and also gave us this high throughput that was made available. As you see here on this stand now, we are capable of doing about 200 million genotypes per day with this kind of equipment in this space. And I think the fast CT or multi-slice CT certainly was another innovation that made it possible for us to have elderly people who are asymptomatic do their coronary angiograms to see if they had disease. And this was a very successful, our first 1,800 we did in the multi-slice gave us a good control group that we could deal with. And as you know, that the first gene risk factor for coronary artery disease came in 2007. One at 9p21 identified by us, simultaneously identified by the DECODE group, and we all published in the same issue of Science back in 2007. And as you can see here, this is the Icelandic group. So this risk variant was on chromosome 9 on the small arm, that's why it's called P, and in the region of 2.1. As you can see here, it now referred to as the Manhattan plot. Along the bottom are the chromosomes, and the skyscraper is 9p21 rather than the usual skyscraper that you see for Manhattan. This was a little bit of surprise. The 9p21 risk variant was indeed independent of known conventional risk factors and clearly is acting through a mechanism unknown and still unknown to us at this time. It's also the first new risk factor for coronary artery in about 4 decades. Now, the risk factor 9p21, if you have 2 copies, obviously if you have bad enough to inherit each of the bad ones from your parents, if you're homozygous, you have about a 40 or 50% increased risk. If you have 1 copy, about 25%. Now, we realized very early in the game that there were multiple genes contributing to coronary artery disease, and each has minimal effect, and it was clear that we probably had to have larger populations than we anticipated in order to identify the multiple genes associated. So one of the things we did, a whole bunch of us, 12 of us, in Europe and in North America, got together and formed what we now call Cardiogram, and it made it possible by pooling our resources of over $250 million to do a large study in a large population, and from that, our first sample size was 86,000. Our sample size now is 196,000 cases and controls. And last April, we were able to announce that we identified 23 genetic factors for coronary artery disease. 13 of them are novel, and 10 was confirming what had already been discovered by several of us individually. And so with this kind of technology, things moved, very quickly. And then at the same time, this was published about April, I think in about May or June, the Coronary Artery Genetics Consortium, they published 4 more. And then came this group, which published 4 more, one single one, which is related only to the Chinese population. And then IBC Consortium came out with 4 more novel risk variants for CAD. So the end result was we now have 36 genetic variants, all of which satisfied the p-value of 5.0 times 10 to the minus 8. All have been duplicated in independent populations of at least over 50,000. And so it's very clear, I think, for most of us that these are well validated and certainly has been shown throughout the world. In the case of 9p21, as you are aware, that it is present in all ethnic groups except Africa. So the world's population at the moment is just over 7 billion, and 9p21 has a frequency of 75%. It's present in little over 5 billion people at this moment, and it's the same frequency pretty well in Koreans, Chinese, Caucasians. But it is not a risk factor in the African population. With 36 genetic variants, one thing that was very clear and is still of excitement but also not anticipated is that 13 of these genetic variants, 23 rather, only 13 of them are in fact acting through cholesterol or blood pressure or what have you. That 23 are acting through mechanisms unknown at this moment, and they remain unknown. But that is exciting because clearly lurking around the corner is another pathway like cholesterol, and hopefully that we'll get the drug companies back someday to do another buster drug. But this is what it now looks like when you look at the equivalent to the Manhattan plot, which I referred to as Beijing only because I gave this talk in China a few weeks ago. Beijing has twice the skyscrapers of Manhattan, so I think it was a reasonable thing to do. Now, this is too small to read, but I want to point out a couple of things. First of all, as you can see here, that the first 8 or so are acting through lipids, and 2 are associated with hypertension. This is a little bit surprised. We expected a greater overlap between hypertension and myocardial infarction or coronary artery disease, but so far that hasn't happened. I might add there are 42 genes identified for hypertension, and so only 2 of them are interacting or overlapping with coronary artery disease. The rest of what you see here are acting through mechanisms unknown at the moment through whatever metabolic or otherwise pathway. And I think that that clearly says to us 2 things. One, if you want to prevent heart disease, you need to know not just the conventional risk factors, but what these are also doing. And certainly when you know that, hopefully it will be possible to develop appropriate innovation. Also, as you can see here, 10 of these genetic risk factors occur in more than 75% of the population. So they're very common. The original hypothesis we had back in 2004, that common diseases must be due to common genes, is clearly proven. These genes are very common. Another 8 of them occur in more than 50% of the population. The most of those risk variants, their increased risk is only in the range of about 20%. So it's a small effect, emphasizing why we had to have large populations. But here's another point here, and this is we only constructed this a few days ago based on 14,000 at University of Ottawa Heart that we've genotyped and done. And what you see here is in blue versus in green, you're looking at the cases. This is the number of genetic risk variants that they have. As you can see, lot of risk variants occur in controls as it occurs in people with disease. And it's the number of risk variants that begin to give you. If you look at the risk here versus the risk here, it's about 2.5-fold. And it's all related to if you happen to have 20 or more of these risk factors rather than the average of 17 or the lower end of 5, that you can see this is where your risk comes. This is based on roughly 21 genes, so the maximum you could have if you got both of them from your parents would be 42. The maximum we observed is about 25, but the average, as you can see here, is about 17. So one thing to take away from this is it's the number that you have, not any particular one. Now, lastly, in ending up, what do we want to do all of this for to get back to personalized medicine? Clearly, what we want to do is to identify genes so we can stratify patients, and secondly, develop new therapies that would target those unknown pathways. What's the advantages of having a DNA variant as opposed to measuring cholesterol or C-reactive protein? First of all, they don't change with time. It'll never change in your lifetime. You don't have to worry about what you ate before or what you're going to do after. It's not affected by the medicine you take because, as you know, the average gene is about 20,000 bases, and the rate of mutation is 1 base every 250 years. So for you and your parents and your offspring, that one's pretty well going to stay the same. So you only need to get 1 venipuncture when you're born, and then you can lock it away with your electronic record. You don't have to take your blood sample again. So that's one advantage, 1 venipuncture per lifetime. Now, I just want to say a little bit about 9p21. 9p21 is the one that was discovered first. It's the one that we know the most about. It is extremely common. And as I indicated, a lot of work going on to try and find out what 9p21 does and how can we use it in terms of, first of all, I think there's universal agreement today across the world, 9p21 has nothing to do with myocardial infarction. It has all to do with atherosclerosis. It has nothing to do with plaque rupture or thrombosis. And this has been confirmed in multiple studies in different parts of the world. And in our own study, and this is work from Iceland showing that 9p21 is not only a risk for coronary disease, but also a risk for abdominal aortic aneurysms and also for intracranial aneurysms. I think that goes along with the idea that its site of action is in the vessel wall, predisposing to atherosclerosis or predisposing to abnormal wall thickness as you think of an aneurysm and not related to a myocardial infarction per se. How does it shape up as a risk factor? And I think this gives you a comparison. If you look at 9p21 in individuals with myocardial infarction before the age of 55 in males or before the age of 60 in females, it has about a twofold increased risk. And it compares very well with smoking, with increased LDL or decreased HDL, and so forth. So it has all the features of a pretty good risk factor, and as I've indicated, it is independent of all of those known risk factors. Now, you may certainly make the argument, let's not use 9p21 until we have a specific therapy that affects whatever 9p21 does. 9p21 at the moment, we have no idea what it does. It doesn't code for a protein. It codes for what's called a long non-coding RNA, and we do not know what it does. Those RNAs work by knocking down other genes that code for protein, but we don't know which gene that is at the moment for 9p21. And if you take that argument, you certainly will wait a few more years, because from the time we knew cholesterol was a risk factor until we got the first drug in 1987 was about 50 years. Now, I think we do things faster today, but we're not going to do it in 5 years. So one other approach is look at the guidelines as we know them today. If you came in today and had a cholesterol of LDL, say, of 180 or something, and you have no other risk factors, they'd say we should get it down to 160. If you had a risk factor, you should get it down to 140. If you got more, we get it down to 100. Well, one way to look at this, if you come in today, regardless of where your cholesterol is, if you have no other risk factors, but you have 9p21, and since it is an independent risk factor, you could make the argument that certainly you should be more stringent and decrease their cholesterol. That, of course, remains to be proven and certainly is not part of management at the moment, but it is one approach to this. It's the same approach as Jupiter took. Jupiter took the approach that with C-reactive protein, if you have normal cholesterol and your C-reactive protein is up, knock down the cholesterol, you'll knock down the C-reactive protein, and what they found, of course, it decreased the incidence of infarction and cardiac events. If you use that approach, then you certainly could start using 9p21 before you find a specific therapy. My last point to make to you is that we do not know what 9p21 is doing. We have done a variety of studies to try to find out. 9p21 came into the genome with higher primates. Usually when you bring a bad thing in, something that will predispose to heart disease, nature gets rid of it and starts to decrease it by evolution. Didn't happen with 9p21. 75% of us still have 9p21. It means it had a good reason to be there. It didn't come into higher primates, and at the same time it came into the genome, so did interferon alpha-21. The interferons came into the genome to prolong life. That's why we have a longer life than rodents, is because we have a better immune system. And, of course, alpha-21, it fights specifically viral infections. So what do they have in common? We decided to measure interferon alpha-21 in the blood of people with disease and without, and what we found, if you have 9p21, you have markedly increased levels of interferon alpha-21. So why are they so linked together? I'm not sure. Obviously, it would suggest that, in fact, they must have something to do with each other. These are controls, but not real controls. They're people who had coronary angiograms done, and they have less than 50% obstruction. Most of them have about 20 or 30%. And you can see that this is the distribution. If you had 2 copies of 9p21, this is the serum level of the protein, and those is 1 copy. If you go to look at people with 50% obstruction, you see markedly elevated levels of interferon alpha 21. We do not see that unless you are positive for the risk allele 9p21, so there must be something going on. On the other hand, if we do the C-reactive protein, we see no relationship between C-reactive protein and 9p21. So, in conclusion, I think two things to take away. Clearly, over 2/3 of these genes are acting by a mechanism we know nothing about, and that's exciting in terms of possible drug targets. And secondly, you're going to see much more of this. The total number of genes identified since 2005, taking all the diseases, 164, is now over 1,200. And so it is a major movement. On the other end, don't be fooled by the fact you can do a 200-chip gene in 45 minutes if you want to. So that barrier is certainly over with. You can take this to the bedside, and I think that over the next few years, my most excitement will be identifying the next big pathway, such as cholesterol, so that you can have more effective therapy. Thank you.
Thank you very much, Dr. Roberts. Ladies and gentlemen, we do have a moment here if we have a couple of questions for Dr. Roberts. And don't go away. I want to let you know that we're going to be playing some taped educational content up here on the screen about biomarkers. This directly pertains to what Dr. Roberts was just talking about. So we certainly encourage you to stick around and watch those presentations as well. In the meantime, do we have any questions for Dr. Roberts? Right here?
Thank you. What is the role of epigenetic?
Sorry, I can hardly hear you.
What's the role of epigenetics?
Yes.
And, in risk factors in combination with this?
The question is epigenetics, just to make sure if everyone knows what that means. All of those changes we are looking at is a change in the sequence of DNA. Epigenetics doesn't change the sequence. It puts a methyl or ethyl group on a particular base so that it isn't transcribed. And those markers we use at GWAS, they will pick up whether it's epigenetics or whether it is a change in sequence. So of that 23 we don't know, some of them may in fact be an epigenetic change, but we do pick them up. And so I think epigenetics, from my perspective, could play a significant role, but it's already captured in the GWAS.
Any other questions over here? Excuse me for a moment. I want to make sure that everybody can hear you.
A very clinical question. In your practice, when you have somebody who has coronary disease and has none of the current risk factors, LDL being very low and not smoking, no hypertension, no diabetes, etc., do you normally run these tests in a clinical fashion to give them some guidance for them and their family?
We do not normally run them, but if the people who have been tested in our studies, they have the right to ask us, are they 9p21 positive, for example? And some people do, and we then, of course, must oblige them and tell them if they are or not. And those who are positive for 9p21, and many of them, of course, came to the test because they have a history of heart disease. And what we do if they're positive for 9p21, we do as I indicated. If their cholesterol's in the normal range, we treat it and bring it down lower. If they're hypertensive, we take care of that. So we are more intense with conventional risk factors if they're positive for 9p21. Obviously, we have no other specific therapy for 9p21 at the moment.
Do you do their kids?
We do not do their kids unless they ask, but often they do, and we have done some, yes. And we've taken the same approach, and very clearly within families, you'll see 9p21 is indeed moving through the family.
Any other questions? Very good. All right, how about another thank you for Dr. Roberts?
Thank you.